Welcome to the Talking HealthTech podcast. My name is Peter Birch. Today on the show, I'm joined by Declan Kelly from Eolas Medical. G'day, Declan. How you going?
Hi, Peter. Great to be here. Thanks so much for having me on.
It's great to have you on the show, and we've spoken in various countries throughout the world at events and chatted a lot online. It's great to have Eolas as a THT Plus community member as well. So lovely to have you on the podcast because, there's a lot of knowledge in healthcare and it needs to be managed. And I think there's a lot of people interested in potentially spinning the wheels in terms of how to do it effectively, and love the way you think about some of this stuff. So let's get stuck in. For those unfamiliar with yourself and Eolas Medical, firstly, for those listening in, spell EOLAS, that's probably a good place to start, actually. Tell me about the name.
Yeah, 100%. Yeah, pronounced Eolas. So if you imagine, just drop the E and then Eolas. That's the easiest way to think about how to say it. So it's the Irish word for knowledge or information. And it was all stemmed from really a problem that we were facing in our own hospital. When we were treating patients, myself and my colleagues, we found it very difficult to access the knowledge or information that we needed at that point in time. Specifically, our own internal hospital's content as well. For this patient in this hospital right in front of me, what are the next steps? What should I do for the patient? And we did a bit of research around that as well. And we found that there are over 2 billion medical decisions made every single day. And most of the time, the world's medical knowledge or streamlined contextual-based medical knowledge isn't queried for those decisions. So that's really where Eolas was born. And we launched it in our own hospital, and now it's scaled to hundreds of sites across the world. So, that's a bit of the background on the name itself.
Yeah, really interesting. And I want to unpack that a bit more because, to your point, and I think about healthcare generally, the not to get too existential about it, but there's, clinicians consume a lot of knowledge and try and retain that as much as they can. So then they can engage with patients and the system to try and utilize bits of that information from memory, I guess, and also from the continued learning they do, but obviously as well, other resources and things. That's a heavy load on those individuals and everything, and we try and do it in a standardized way. I guess, to try and apply a better process to it, it's that's a big task. Take me through a little bit more about how you think around this concept around knowledge management in healthcare.
Yeah, so broadly speaking, how we think about it is there are two broad sources of knowledge that healthcare professionals need access to. This is external medical knowledge, i.e. what is the latest evidence for this condition that I'm treating right now? And then there's the internal context-specific medical knowledge, i.e. for this health system, what do I actually do next? What's the referral pathway? How do I phone the social worker? Things that are either in people's heads or they're on some really out of date intranet system. And that's just as important as the external medical knowledge. If you think as a doctor, how often do you see a patient and think, oh, I really want to know what the latest, cutting edge medical treatment is for this patient? Yeah, you make those type of decisions like maybe a few times per week max, just depending on the specialty. The decisions that you make more is what's the number for the cardiology doctor because I have a STEMI in front of me and I need to refer them. So there's all of that type of content that's not organized as well. The way we think about it and view it is, those 2 billion medical decisions in context, there should be the world's medical knowledge and your institutional knowledge queried in real time for that patient, because it makes for better decisions, safer decisions, and faster decisions. And now the technology's here. It's like that phrase, the future's here. It's just not evenly distributed. So we believe this is a distribution problem, really. And that's why we went about building Eolas. So it's about supplementing that external knowledge with all of that context-specific internal knowledge. And now the space has obviously exploded. You have open evidence raising hundreds of millions on billions of dollar valuations, and you have lots of other competitors now coming into the external knowledge space. So, and you've OpenAI have just thrown their hat into the ring clearly with their latest updates and all of their rhetoric. So yeah, it's a really exciting space to be building in.
Yeah. And when you say building in, like, what does that look like? Like because people are accessing multiple, like you say, intranet sources of information and just retaining knowledge, but also there's all the EMRs and all the systems we use. What does that look like from your side in terms of building a product to be able to do that?
Yeah. So again, it's back to this two streams, external versus internal. So the external, we don't write or create any of the external content ourselves, obviously. And so it's all about partnering with the expert content creators there. licensing journal articles to make sure you have the latest up-to-date medical evidence, partnering with guideline-based bodies to make sure all of that evidence is there ready to go. And then what we do with that content is we use computer vision to extract all of that knowledge to make sure that it's actually extracted with high fidelity. The reason why we do that is because a lot of the time there are a lot of figures, there are a lot of charts, there's a lot of flow diagrams that aren't extracted with high enough fidelity if you're building a traditional search system. So we build a computer vision, or we partner with a computer vision model to be able to extract all of that information. And we do the same thing then for internal knowledge. So the internal knowledge, it's less of a business development problem and more of an actual product problem and crowdsourcing. So how do you become the world's largest collection of internal medical information, essentially? And you have to partner with the health systems. You have to partner with the healthcare professionals that work in those health systems and allow them to upload the content that they have available to them. And then also collect all of that tacit knowledge. So what I mean by that is all of that practical knowledge of, how do I phone the radiologist on a Friday evening when there's no one in the radiology department? Really, really practical knowledge like that. That's really a product problem to crowdsource that information. So it's a full spectrum of knowledge that users need to access. And back on the computer vision aspect of things, one of the reasons that led us down that path from a tech stack point of view is if you think about all of the internal documents inside a hospital, they're usually a flow diagram built in Microsoft Word about 10 years ago by someone. And it's, if this happens, then do this thing. And then it's a circular diagram. If you upload that to any traditional large language model without visual capabilities, it just loses so much of the context. So that's one of the major reasons why we went down that path as well. So we extract all of that information. Doctor asks a question, gets an answer within seconds.
Interesting. And I think about the available technologies we have these days, and one of the most exciting potentials around artificial intelligence is, when we talk about large language models and even some other kind of variations, is the ability to consume a lot of information and then present it back to someone in a more tacit format. How do you think about the role of AI specifically around, say, knowledge management? Because there's some of it, we talk a lot about the potential for what it might be able to do, and other times we're actually applying it in a day-to-day. What's your take on it at the moment?
Yeah, so I think the technology is now there. It's back to that phrase of, the future's here. It's just not evenly distributed. The distribution bit is the difficulty here, because it comes with clinical safety and it comes with regulation and it comes with trust. And they're the things that need to be nailed. They're the questions that we need to answer as a community and as a collection of health systems around the world, of how confident are we if this gets things wrong? What is our level of risk tolerance? What should our approach to regulation of these technologies be? And therefore, how should we apply them at the point of care? And it's very interesting to see the different approaches globally around this. You have the US with slightly less regulatory heavy approach, and things are scaling very, very fast. And then you have the EU and the UK, and that's a much more heavy regulatory approach. And it's interesting to see the two different approaches evolve. Ultimately, you can't just take GPT-5 and just put it at the point of care for patients. That's not safe for patients, and that can't be done. So all the processes need to be built around that, and how the data is extracted, how it's managed, what medical device certification level that it has, privacy concerns as well. So all of those things, that's what needs to be figured out, so that you can go to a health system with confidence and trust and say, this is what we figured out. This particular large language model, whether it's GPT-5 or Gemini 2.5 or whatever it may be, this is just one small single point in the long chain of this process of managing and accessing this data, but it unlocks the ability to seamlessly embed that data and that knowledge at the point of care. So it's fundamentally pivotal, but it's still only one small point in a long chain of processes that need to occur.
And what's interesting, and probably to your point earlier around, our risk tolerance, and I think you were speaking more about, how much are we okay with if, say, an AI was to get something wrong, and what was the potential of that? Think about other risk tolerances that people make, be it a clinician working within a hospital or even from a patient's point of view. One reason why patients will put all of their medical history into a conversation with ChatGPT is because it's right there, and the response is immediate, and you kind of feel like you're being listened to. you probably don't even have to log into anything if it's already logged in, and there's no real hoops to jump through. And then I think from a clinician's side, when there's a lot of pressure on, we see a lot of shadow IT or other tools kind of creeping in because the existing system's not supporting them, or it's they just need to get something out or find something out really quickly. So I guess there's a pretty important role to play. Like, we could put all of these controls and systems around for, if everyone was to use everything in the perfect way, then, everything would be safe and secure. But if it's too locked down or not accessible enough, then no one's going to use it. So do you think about that often in terms of how much is super easy to use versus super secure and tight?
Yeah, every day, because that's the type of thoughts that I have in my head. So yeah, I think we're at a really interesting time in healthcare and health technology, where for the first time over the last 5 years, we're seeing product-led growth and bottom-up adoption of health tech actually work as a go-to-market. You're getting a lot of scribes, for example. Heidi, that's their model, PLG, bottom up, and they've been extremely successful in lots of different geographies. And then you've got open evidence in the US, 0 to 40% of all doctors in a very rapid period of time, because doctors want to use that. Alternatively, you had UpToDate, which would go into hospitals, sell to hospitals, an enterprise-wide license to hospital, then trickle that down to their users. And that's generally the historic model. So we're now seeing this massive shift towards product-led growth, direct to clinician, and that type of adoption. That's that will clash and is now clashing. It's very, very frustrating as a chief medical information officer or as a CIO of a hospital to see then a lot of clinicians using tools that maybe don't have the highest levels of governance or have maybe privacy concerns or privacy issues. The question just is, how will this play out? What ultimately will happen here? And I think that's again where countries and different geos are diverging on what the approach is to regulation, what the approach is to privacy and safety. And you're seeing a lot of different approaches, in the UK and EU than you are in the US. And it'll be really interesting to see actually what actually happens there. You have open evidence going, direct to clinician with their knowledge base. Now they're going straight to direct to clinician with a scribe, and they're moving down that pathway. That scribe is collecting patient data, and they're moving down into that pathway. So it's really interesting to see what actually plays out. I don't know what the answer is going to be. I don't think anybody knows what the answer is going to be, and I think there's going to be a balance. But I think the most exciting thing is that there's a clear demand from clinicians that the software that they're using at the minute isn't good enough, isn't solving their problems, and they want to adopt stuff that does.
I love the AI scribe example. It's probably been overdone a little bit on this podcast, but prior to, like, if there could be the technology community that might complain that clinicians are slow to adopt technology, or they'll generalize and say, clinicians are stuck in their ways. But then as soon as a tool is super useful and solves a problem, then 100%, then you see clinicians kind of going around, like, even with kind of some unanswered questions, in the end, that kind of it's interesting to think about, if there is a technology provider out there thinking, well, if only clinicians were more, thinking innovatively, maybe the problem also is the problem actually being addressed.
Yeah. I suppose the thing is, like, as a doctor myself as well, like, the experience is there, and you don't really have a lot of say in what you can use. Like, the knowledge bases and the ambient listeners to extent are almost edge cases. You're not going to be able to adopt your own EHR from a bottom up approach. So as a clinician, you actually don't have a lot of autonomy, but there is a lot of demand in general, and that's interesting to see where this kind of clashes.
Yeah, and then, like, another thing we talk about a lot is the load on clinicians and the responsibility or the need on a regular basis for a clinician to manage a lot of things going on. So internally, cognitively, might be recalling their own medical knowledge and expertise, but also, to your point earlier, probably more of the battle sometimes is how to procedurally do something correctly, not surgically procedurally, but just operationally procedurally, how to contact a particular person or ensure someone doesn't get lost through the cracks. And then there's a lot, sometimes, depending on in such a human-centered, the intention is healthcare is quite human-centered. So it could be one could forgive a clinician for being quite, emotionally attached to processes and ensuring patients are cared for, and that's a lot of load that a clinician, and you obviously would know that much more than me, being a clinician yourself. Is there a role? There's got to be a role for then artificial intelligence to alleviate some of that, or are we kind of adding to the problem? What's your take on it?
Yeah, of course. I think it's we have to focus on what the actual problem is at hand, and what problem needs solved, and then frame it through, okay, what technologies are able to solve that problem. And I think that's the point you need to start with as a clinician. And as you said, it's very difficult to stay up to date with the world's medical knowledge, but it's also very difficult to access what is the process in your hospital. And just to frame that of why AI is so powerful for both of those, on the external side, medical knowledge doubles every 73 days now. If you graduated medical school in 1950, it would double every 50 years. So all the stuff you learned, most of that would be fine by the time of the end of your career. Now in 2025, it's estimated it doubles every 73 days. That's more information than any doctor can read in a lifetime. So that we need AI to be able to surface the information properly and effectively and safely there in that situation. With regards to the internal content as well, then doctors are lost. Doctors move around hospitals quite often, and there's not just doctors, nurses, pharmacists, every healthcare professional. They move around departments. There's new staff that come and go quite frequently. Processes change. Numbers change, pathways change, etc. And my colleague posted recently about a case that they'd seen. It was a very sad case of domestic abuse that they'd seen when they were a junior doctor. And they had seen the patient, within about 10 minutes, they'd realized in the consultation what was actually happening. And they were like, how do I send this patient? Where do I send this patient from a social worker point of view? What pathway do I put this patient on? How do I make sure this patient's safe? Accessing the world's medical knowledge around, this is how you manage that is pretty useless in that case. You actually have to know exactly in my hospital what's that case. And most healthcare professionals then don't know where to turn. Is there a policy on SharePoint for this? Is there something on the intranet for this? And you spend 20 minutes searching while there's someone's life is crumbling around them. So that's just one tiny example of all of the information that you need to get access to immediately as a healthcare professional. And we're underserving the healthcare professionals, then not giving them this information, not giving them these tools, sending them out into the world to treat patients and make decisions, but not giving them this information at their fingertips. So that was really frustration that led us down this path to do that. And the team at Eolas, so we're a team of 7 people, 5 of us are doctors, and 4 of us are software engineers that have built this. And it was just built from that core of frustrating, just that you see the patient and there's something, you want to make the right decision, but you don't know where to turn to get that information. And it's just that anxiety, those kind of 4 minutes of anxiety of where do I get this information from, that's ultimately what we're solving.
Well, take that example or anything like that example where it doesn't matter how neatly the SharePoint is in folders and subfolders. I think that if you don't know where to turn, what does that look like then? What does good look like in that scenario? Is it a free chat thing going on? What's the solution?
Yeah. So the solution needs to take into account 2 key stakeholders, essentially the person consuming that information when they need it and the person managing that information. So it's really important that information is managed properly from a governance point of view, and the admins of the hospital are able to upload, manage, version control, track changes. That's important because you're solving their problem, you're solving a governance problem. But then a lot of the time, the knowledge management platforms only focuses on that. It's we have a policy management system. This solves that problem. It's they're look at all the version control, but it's but no one can access it because there's not a computer on the ward anymore, or there's only 2 and there's 14 doctors. So you have to solve the other problem as well. And because there are thousands of potential policies and thousands of potential pieces of information, it's impossible to read through all of that and try to find exactly where you need to go. So that's exactly where AI and RAG-based search or fine-tuning the model comes in, where you have the intent, you have the question in your head, you just ask the question, you get the answer. And that's the big shift that has happened, obviously, over the last 4 or 5 years, which we've moved from using search engines to using answer engines. So, 4 years ago, you'd search for a keyword term. You'd search for, STEMI management or heart attack management. Now you search for what is the best antiplatelet to use for STEMI. And it shows you the intent. It brings you exactly to the number of chunks that are included in your knowledge base and brings you the answer in a concise format. So that's the big shift that we're seeing, in every industry, and now we're starting to see that shift in healthcare as well.
Love that. Even when I, ask in a non-healthcare capacity, ask any large language model, or I love the concept of a answer engine as opposed to a search engine. I'll get the response back, and it might be quite comprehensive, and I'm like, cool, I trust you, bro. And maybe there's a reference there or something which is kind of nice, but then you click on it, and then the reference takes you off to a 404 page,
40-page document.
It's made up, right? So in healthcare, that if I'm just trying to answer questions about what's the best cricket bat to get for the kids, that's fine. But in a healthcare setting, that's not okay. How do you ensure that trust and safety and security? Because if you don't have the rigid systems and the confidence that when you ask a question, you're going to get an accurate response back, then no one's obviously going to use it.
Yeah. Exactly. Yeah, no, that's a brilliant question. So that's exactly the reason why we use computer vision as a part of our ingestion pipeline. So every single document that's uploaded to the platform, we extract the knowledge from that using computer vision, and that allows us to do something really important, which is called visual grounding. So every time we give an answer, we actually physically show the exact guideline that answer came from, as in the snippet that it came from. Because if we extract, diagrams, text, flowcharts, etc., we take the coordinates in from that document of exactly where that answer had actually come from. So if you ask a question, if you click the reference, it brings you on the same page down to that exact diagram where you got that answer from, where the system got that answer from. So 100% of the time you have source attribution, and that's why it's so important. A lot of medical knowledge is locked away in tables, figures, diagrams, flowcharts, and traditionally you'd had a lot of hallucinations from other traditional large language models. So that's why it's really important to extract the content with very high fidelity and then do 100% source visual grounding.
That sounds pretty cool. And conceptually, all 100% on board. But as you know as well, it's one thing to build a piece of technology, but then to go live and put it in a healthcare setting with all of those other external kind of variables happening, including the humans that engage with it. Anything can happen. What's your take on the adoption and interest and everything, particularly around your solution, but even just generally around artificial intelligence? We talked a bit about the AI scribe edge cases and stuff, but keen to get your take on what this looks like in the real world and how it fits into workflows and all of that.
Yeah, 100%. A great question, and I suppose I can frame it in two parts. One is Eolas's adoption and how that's scaling, and then how we think about what good looks like with regards to deploying this type of software. So on the Eolas side, we have over 350,000 registered users using the platform millions of times per month to get the answer to their question seamlessly, and that does a lot of things downstream. So it allows you to get a lot of data and analytics as well associated with what type of questions are being asked, how robust is the knowledge sources, what the feedback is for each of the answers, etc. So it allows you to build that content flywheel as well, which is extremely valuable for multiple different reasons. With regards to then continuing to deploy that in the healthcare system, I personally think it needs to be done in a stepwise fashion because it needs trust. And I think there's this. It's back to the chat we had earlier there about almost Silicon Valley-esque mentality meets healthcare, which moves at a glacial pace, and Silicon Valley doesn't wait for anyone. And you're having these two clashes of culture. I think I've heard a phrase. It was Hugh Harvey actually from Hardy and Health that posted this, but healthcare moves at the speed of evidence, and I think that's really important. If you're going to be the knowledge backbone infrastructure for a health system for the next 50 years. You have to make sure that the entire system trusts that it's proven to be clinically safe, that it obeys by the laws of that country from a regulation point of view. And you need to take the time and effort to build those processes and build that trust. So how we deploy this is we deploy it initially to individual departments in each hospital, and then use that as a test case, use that to gather the evidence and the safety and build that trust throughout the hospital, and then slowly move it to each other departments. And currently it's standalone. So doctors use it, they ask a question and get an answer. Now we've built an API that allows ambient listeners and electronic health records to query that to get the same knowledge and the same answers. So we can build on the trust that doctors use this. You can show the evidence of how safe it is. Then you can start slowly embedding it at the point of care, and then you can get it more deeply into workflows. So that's really the stepwise fashion, and it's all about collaborative relationships and working with the health system. You can't just impose this technology, even if all the doctors are saying, yeah, we really want to use it. There's a lot of other stakeholders that need to be considered as well. So it's about that stepwise fashion to get this distributed and get it to the point of care everywhere.
As you're talking, I was doing a bit of reflecting actually on like back Talking HealthTech, this will be episode 560 something that's released. And, the conversation started back in 2018. Some of those conversations from the early episodes could very well run today in 2025 because it's about how much we need interoperability, how much we don't like fax machines. And sometimes, whilst we've seen progression, it's not too much change. I don't think, though, in those early years of Talking HealthTech conversation, so, 7 years ago, none of the conversations were around, like the potential for something like large language models and AI to help clinicians consume a lot of, and find a lot of information. I think the AI conversations back then were around the diagnostic piece and probably a few other elements, and particularly billing as well. Then I think about today now and the rate of change that's going on. Are we like, what's the next phase? Like, where are we going with this? Is this the end game? Is this what we're kind of, optimizing for? Is this the kind of next step on to something else? Because I feel like, everything's compounding and we all need to move faster and think more innovatively on where we're going to next. And some people's take on it as well, the next iteration is that we're just working ourselves out of a job entirely and let the robots do all the healthcare, which I don't think is the answer either. So what's your kind of view on where things directionally are going and as we're building out these cool tools?
Yeah, so I think the way I think about this is, what does healthcare look like in 1,000 years' time? What
I've never thought about that.
Yeah, do you go see a doctor in 1,000 years' time? If you're not seeing an AI in 1,000 years' time to do your healthcare, like something seriously wrong has happened in humanity. Now, this is just a very general, high level view. Like LLMs definitely are one very, 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 very small part of that. It's not going to get us AGI. It's not going to get us to the point that we need to get to, and they're only a very, very small part of this. And we have to stack lots of different technologies on top of each other. But if you think about it, what does healthcare look like in 1,000 years? And we can all use our imaginations. So if I think most people agree that it's going to look like something mad and futuristic, and it's not going to be the system that we see in place. So if we start using that as an analogy, okay, it will look extremely different. Okay, so what does it look like in 500 years? What does it look like in 100 years? What does it look like at 50 years? At what point does it start not looking like the way it looks like now? And then how do we get to that point? So that's kind of one aspect of how I think about it from a top down of like, where does healthcare go? The other aspect is like looking at it from where we are right now. It's very clear what happens in health tech is there's this bundling and unbundling of health technology providers. So you have, maybe 30 years ago, just EHRs when they first launched, and everyone then starts getting on the EHR. Now you started people saying, actually, wait a minute, the EHR doesn't do, note transcribing very well. It doesn't do knowledge retrieval, doesn't do all of these things very well. So you get a demand from the market for all of that stuff. And that's enabled by the latest technologies. So you get the ambient listeners, you get the knowledge bases that are AI powered, and you get all of this unbundling. Then you get a rebundling again. So you get Epic launching their ambient scribe, Epic partnering with all the knowledge bases, etc. And all of this then comes towards a singularity, which is Epic and Microsoft, really. And that comes towards that point. But then what happens is that bundle isn't solving one other problem, and it's probably then enabled by a new technology that comes along, and then that starts to unbundle again where providers. So you get this unbundling and bundling. Ultimately, if you follow that down, you get this path of almost as you say, a singularity where there's a computer vision model able to look at your moles, look at like all your heart scans, look at all your radiology. There's the knowledge base is able to query all that in real time. Ultimately, I think Eric Topol's book, Deep Medicine, summarizes very, very well. It all needs to be, all of the complexity around that needs to be abstracted away so that we can deliver medicine from one human to another human. I think that's the key. All of those things are just enablers for us to be able to practice medicine in a better way. 4,000 years ago, there were doctors. They practiced medicine in a very different way than we do now. There's doctors now, and there will be doctors in 4,000 years' time. They'll just be using different tools. And I think using it, having that as a mindset of a way of how do we interact with patients, how do patients want to be looked after, that's the thing that kind of inspires us and inspires me anyway.
I forgot I was doing a podcast recording for a second there. I was really enjoying that. And I've not thought about that. I'm going to be reflecting on that for a little bit more actually. So thank you for that. I'm sure others will think the same too. And so then, as we start to round out the conversation, then for Eolas and what you're working on and what you're building, where does this kind of the asking functionality, where does that fit into the bigger picture for Eolas?
Yeah. So I think, again, the way I frame it in my mind is those 2 billion medical decisions that are made every single day, 23,000 medical decisions made every single second, what percentage of them had the world's medical knowledge queried for that patient? That's when this wins. And Eolas, we want to have as many of those decisions informed by Eolas's knowledge base. I think it's important that there obviously are multiple players in this place, just with any healthy marketplace. But that's the goal here. How many of those 2 billion decisions are actually informed by the latest evidence or context specific information for that patient? That's kind of how we obsess about that, and that's what we measure, as a KPI.
Love it. So, Declan, I will make sure that the details for Eolas are in the show notes of this episode. They're all on our website as well as THC Plus company partners. And looking forward to chatting more in the THC Plus community as well. Always a pleasure, man. And great to chat, and looking forward to seeing where things go next. Thank you so much.
Yeah, 100%. Cheers, Peter. Love being on. Chat to you soon.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.